So the interstitial compartment is basically separates out the intravascular compartment from the intracellular space. Okay, this compartment space is actually very important because it allows for nutrients to be deposited there as well as oxygen, and you also have your waste products being deposited via the cell into this space. And the analogy basically is think of it as a truck in the road, and the interstitial space is basically the road between your connection between your house and the road itself. Okay? The chemical composition of incoming blood is very important in controlling this interstitial space. The interstitial space is different than the intravascular space, even though it's considered an extracellular compartment. And the interstitial space normally does not have any red blood cells in it. It also has a lower concentration of proteins that are normally found in intravascular space. Now, the functional arrangement of the cardiovascular system is the right side of the heart pumps approximately 100% of its cardiac output into the lungs. Okay? Pulmonary blood flow is actually a very low resistance system in comparison to systemic circulation. It's a 20-to-1 difference. Okay? So you can see that the pulmonary vascular resistance is actually very, very low. Okay? The gas transfer takes place at the lungs, okay? And certain kinds of metabolism is also taking place in the lung, especially like breakdown of epinephrine. Overall, this system is a low-resistance system. The left side of the heart is going to the systemic circulation, and that's into a high-resistance system. When you go back to this picture, it shows you how the blood actually preferentially goes to different organ systems depending on the vascular resistance to those components. Okay? This is a system in series, the one that goes from the right heart to the lungs to the left ventricle. This one, on the other hand, is a system in parallel. Okay? And you can actually determine which one of these will have more resistance to which one has the greatest blood flow to it. One of the things that the brain tries to immediately protect itself in case of in shock situations is that it basically constricts all the other organ systems to basically preferentially distribute blood to itself. The left side requires a high-resource system in the sense that it requires a lot of workload due to its high resistance. Okay? The system in series is the right and left side must have the same cardiac output because they're in series. That's a very important concept that you will talk over and over again. When you actually do cardiac output measurements via Swan-Ganz or PA catheter, it's basically we're shooting cardiac output in the right ventricle. You're not shooting it in the left side, but it has to be the same. So even though your right-sided cardiac outputs are being actually measured, you're actually measuring both because they always have the same amount. The actual amount of volumes in both ventricles are also essentially the same, and the amount of volumes that are actually being pumped from one side to the other are essentially the same. So stroke volumes are the same in both ventricles. The actual organs, the normal cardiac output is around 5 to 6 liters per minute. Once you're pumping out systemically, the organs are parallel, not in series, which is what I just showed you about. What are the blood conditioning organs? These are responsible for altering composition of blood. They can tolerate decreases in perfusion. Things like lung has a significant amount of capacitance in it. Only about 1/3 of the lung actually has blood in it at any one time, okay, when at rest. But at very high cardiac output states, the lung will fill up with a considerable amount of volume. So you have a 2/3 reserve volume that you can accept. And you think about it in this way. Remember, normal cardiac output is around 4 to 5 liters per minute. Okay? But when you exercise, you can go up as much as 12 to 15 liters per minute. So where are that extra volume going? It has to go to the lung. So in the lung, the way it does it is it accepts it because there's much more volume that it can accept. So it can do this very easily. Once it gets above a certain limit, so in other words, if you take the lung and cut out a portion of the lung, immediately what happens to the ability to accept more volume? Goes down. So performance immediately drops. Okay, that person is much more likely to develop pulmonary edema. If you increase the flows too rapidly in that individual with one lung, you can put them in pulmonary edema very rapidly. The kidneys are out here in the parallel system. It's a major excretory and filtration system. Your GI is, of course, responsible for nutrition and water intake. Liver is responsible for metabolism, especially creation of proteins and lipids. And skin is, of course, important for temperature and alteration of compounds as well. Organs that have only adequate perfusion and do not tolerate decreased perfusion are the brain, cardiac muscle, and skeletal muscle. These have very limited time periods that they can survive without oxygen. The most sensitive, of course, is the brain, which is under 5 minutes. So at 5 minutes, your brain basically starts dying. Cardiac muscle can last maybe up to 15 minutes, and skeletal muscle anywhere between an hour to 2 hours, depending on which one you're talking about. The basic physics of blood flow is that your blood has to be regulated to where it goes. The body is constantly changing resistance, and as a consequence, varying where perfusion is going to different organs. Okay? The rate of fluid flow basically has to be thought of a fluid going through a tube, which is what all your arteries are. So you have to consider either laminar or turbulent flow. At very high velocities, most flow becomes turbulent. Okay, so flow that comes out of the aorta, immediately it becomes turbulent flow. It's not until you get into more of the arterioles distally where you start talking about laminar flow. Okay? In laminar flow, the way you have to understand it as an analogy is think of it as a river. Okay? If you think about turbulent flow as a rapid river, like a rapids, you see it bubbling and moving very quickly. That's in the aortic arch. That's moving very, very fast. Okay? As a consequence, you can get more air bubbles formation as well in that kind of situation if it was allowed. Okay? But when you get further down the road, it's more like a river that's not the rapids, and you see the laminar flow in the middle of the river is actually faster than the edges. Okay? On the edges of the river, where the river banks are at, there's more resistance, so velocity begins to slow down on the edges. And the same thing happens with blood flow. Okay? For flow, the pressure is a difference over resistance. It's volume over time versus perfusion pressure difference, which is something that we talk about constantly. Okay? Perfusion pressure is just simply the amount of pressure being put in versus the pressure putting pressure back against it or slowing it down. Perfusion pressure, things like you will be discussing will be coronary perfusion pressure, things like cerebral perfusion pressure. Sometimes we'll also talk about spinal perfusion pressure. What they're talking about is what is the pressure coming in that's driving the blood into that area, and what's the resistance that's basically preventing that pressure from going in there, which is usually the venous pressure, is what we're talking about. Flow, on the other hand, is actually amount of volume over time, which is very different. I wish we could monitor flow more easily, because that really tells you what perfusion is really taking place in that organ. And if you look at studies that are talking about perfusion, flow, those are much better studies. Okay? Studies just using perfusion pressure are easier to do, but the limitation on them is you don't know how much volume is really reaching that organ system. Okay? So don't confuse those two. There's a big difference. Okay? Blood flow can be changed by changing the pressure difference, which is why systolic pressure sometimes an increase, but also are significantly affected by the length of the tubing. Okay, the longer the tubing, the more resistance, and the smaller the radius, the more resistance. Okay, the way your blood system can regulate this is it doesn't make your blood vessels longer. That doesn't work that way. Instead, the way it actually alters resistance is by narrowing the blood vessel. Okay? The only blood vessel really responsible for this is not the aorta. Okay? Make sure you understand that. It's not the aorta. Aorta is not responsible for altering resistance. Resistance is managed at the arterial level. And that's a critical aspect. That's where the sympathetic nervous system goes to control the diameter of the blood vessel. There is no parasympathetic control of arterioles. There's only sympathetic control. There's also local metabolite control, which we'll talk about all that later, that also regulates arterial vasoconstriction. Okay, so the way your body really controls blood flow to what organ system when you're talking about systemic circulation is through resistance of these arterioles. Okay? You can go into all this, and Dr. Mike will talk to you about this in chemistry and physics. so I'm not going to go into that. I don't expect you to memorize these equations. I just want you to understand the concepts that as you increase resistance, flow begins to decrease. If perfusion pressure decreases, flow decreases. Those are the concepts I just want you to have in your mind. Okay? So flow can be controlled by maintaining adequate perfusion pressure, which is the top part of this equation. It's very dependent on the control of the vascular radius. The length and viscosity cannot be altered very easily in the human body, but it does occasionally occur, not so much the length, but the viscosity. When somebody begins to hemorrhage, viscosity drops normally, okay, because you're usually giving that person crystalloid, so that person's viscosity drops off. If you begin to give the person a lot of blood products, especially without diluting out your red blood cells, you will notice that your viscosity increases and actually can cause a decrease in flow. Areas of low resistance receive usually high flow. Okay, so this is the basic concept of showing you flow through here. This is the perfusion pressure going in versus the output back pressure, which is this is your venous side of it. Sometimes we also consider that part of the intraventricular pressures we'll talk about in coronary perfusion pressure. Radius is the important concept here of what most of the body does to regulate blood flow through most organ systems. Now let's talk about the heart. The heart basically is a giant pump, okay, but it's a very, very efficient pump. It's the most efficient pump that actually I can think of, to tell you the truth. If you look at an automobile, the actual efficiency is anywhere between 5 to 15%, and that's considered excellent. Okay? In our body, our pump efficiently works at 70%, which is a huge difference. Okay? The reason it can do this is because the heart is actually pumping into elastic tissue. Okay? It's actually pumping into a conductance vessel that is able to expand, which is the aorta. If you look at the aorta, it actually expands every time the heart pumps into it, which is accepting the volume, and then when the valve closes back down, the aorta itself compresses and maintains your diastolic pressure. So if you had a rigid pipe in your system, the performance would drop off dramatically. That's why vehicles that we have, which are all metallic, which are non-elastic pipes, can't maintain a high efficiency. Okay? The hydraulic pump, which means how well the heart is pumping, can be described via a simple equation which you have to memorize, which is cardiac output. Okay, cardiac output is a simple equation of heart rate, how fast the pump is working, times the amount of volume being displaced, which is stroke volume. Stroke volume is the effective amount of volume that's being emptied out of the heart. Okay? So cardiac output, though, is comprised of two components, heart rate and stroke volume. You've got to remember that. A lot of people forget that, and they see somebody with a heart rate of 120, they think everything's okay if the cardiac output comes out okay, and it could be that the person has a very low stroke volume, which means that person's in failure. Okay? Gross anatomy is different between the ventricles, but the waveforms end up being identical. And when we do this next semester and make you do the workbook, the cardiac workbook, you'll be getting a little bit more of a working model of that as well. Okay? But one of the things I think you have to understand is that the ventricles themselves pump the same amount of stroke volume. The right ventricle pumps the same amount of stroke volume as the left ventricle every time. Okay? Anatomically, the right ventricle is thinner in structure in the adult. Okay? The reason being is it doesn't have to pump against a lot of resistance. Okay? Versus the left ventricle has to pump against a high resistance workload. Okay? So it has to be thicker. And the way you think about this is take a person who's a bodybuilder, who is lifting a lot of weights, versus somebody who is just trying to do an exercise where they don't have to lift a lot of weights. The muscle difference is very considerable. One person's muscle will get thick, bigger, which is a muscle with the guy who's lifting heavy weights, versus the other guy is just as strong, but it doesn't appear so because his muscles are thinner, but he still can be very strong. Okay? Both these ventricles are pumping, though, efficiently. And the intraventricular pressures must be greater than the outflow area, which is how much blood is being pumped out. Okay? The intraventricular pressure must overcome that to eject volume out of the ventricles. Okay? One of the things that you're going to become very adept at is understanding what we call the pressure-volume loop. Okay? And this is you have to become understanding this concept because we're going to add a lot of things to this over time. So this is the working model that we use here in the school to try to get you to understand how the heart functions. Specifically, what you're looking at here is this is the pressure volume loop for the left ventricle. So this is the left ventricle. What you have to understand is you have to look at it from the standpoint is imagine that you're looking at, and you're inside. You're inside here. You have a monitor, you have a catheter inside the ventricle. Okay? Inside that ventricle, the catheter does two things. One is it measures the amount of volume that's inside the ventricle. And the other thing it's measuring is the amount of pressure inside this ventricle. So you're monitoring two things. The volume is measured in this direction. Okay? And the pressure is measured in this direction. Okay? Now, what you can imagine at first is we're going to go through the different stages. Okay? During diastole is when the actual heart begins to go through a phase where it begins to relax first, and then it begins to fill. So the point of where diastole begins is when the aortic valve closes. Okay, so this point here is the aortic valve closure point. That's when actually diastole begins. During isovolumetric relaxation, okay, both the aortic valve and the mitral valve are closed. So the actual ventricle gets larger, but the valves stay closed. Okay? That's considered isovolumetric relaxation. If you look at this, there's absolutely no change in volume during this. See, the volume stays fixed. Okay? But the pressure falls down very quickly. So isovolumetric relaxation is that portion of diastole where the ventricle basically relaxes and allows the ventricle to go to its normal resting state. At a certain point, once you get to a low enough pressure, the mitral valve opens. So this guy here opens. And when it opens, it begins to fill with volume. So now your volume is beginning to fill. Okay? 80% of this volume, under normal circumstances, is passive. Just imagine that. 80% of the volume returning back to your left ventricle is actually totally passive. Okay? When you get to a certain point, at that point, which is right here, then you get something else that adds on the rest of the volume, which is the atrium at that point contracts. During that phase, the last 20% of the volume gets deposited in them. So the atrial kick, which is what the atrium contracts, only accounts for 20% of the normal volume returning back into the ventricle. Now, let's give you an analogy. Okay? If you lived in Tokyo and you went to there in a rush hour, you would notice that people would go, when the trains open, the people rush in very quickly into the train. Okay? But then you'd be amazed about something. You'll see that there's 3 or 4 conductors per each car that are called pushers. Okay? The car looks pretty full. Actually, it's very packed. Okay? And you'll see those guys put arms together and push the crowd into the train, which they'll shove maybe 4 or 5 people more up into the train. And sometimes we'll actually lift people off the ground because they're that close together. Okay? That's what the atrium basically is doing as an analogy. It's shoving the last amount of volume it can inside the container. Okay? So that's what your atrial kick is doing. That's 20%. At that point, the mitral valve closes. Okay, so again, you have both valves are closed. The aortic valve is closed, and the mitral valve is closed. That is the point of maximal filling of the ventricle. Your ventricle is not going to fill up any more than that. So that will be considered your left ventricular end diastolic volume, and which is equal to your preload. That's actually how much volume you have inside your left ventricle before it starts to contract. Now, I wish we could monitor that directly, and we are going to eventually be able to do that, maybe in your lifetime. In my lifetime, maybe not, but I know in your lifetime they'll have that, I think, by that point. But we have to, indirectly to measure that, is we use the left ventricular end diastolic pressure. So if we have a catheter inside the ventricle and we can measure that, we can actually do that. The reason we don't do that is because the catheters inside the left ventricle cause a lot of arrhythmias. So we'll infer it by what we call the PA occlusion pressure. So the PA occlusion pressure ends up being the equivalent of left ventricular end diastolic pressure. Okay? Have I lost anybody at this point? Okay, good. Now, the next thing that happens is that the heart begins to contract. And as it contracts, this ventricle becomes smaller appearance-wise. But what happens to the volume inside here? It's staying the same. It's squeezing it down, but the volume is actually staying the same. That's called isovolumetric contraction. And that's why you're seeing this line going upwards like this. Okay? That's the isovolumetric contraction phase. 60% of your workload energy is dissipated in this work. So it is the most difficult part of the heart to work. Okay, so that's when if you're going to have a higher risk of having a myocardial infarction, if you increase that workload, you're increasing the risk. Okay? Eventually, your pressures overcome the aortic valve resistance or the diastolic pressure in your aorta, and it opens up the aortic valve. Okay, so this point, let me just go back and make two things. This point here is your preload. This point here, which is when the valve opens, is your afterload. Okay. When the valve opens, it empties rapidly, which accounts for this, what we call the stroke volume. So when we're shooting cardiac outputs, this actually mimics the amount of volume being displaced out. Okay, so in other words, when you're looking at your pressure volume curves, when you see somebody shoot a cardiac output and they tell you the stroke volume is 50 to 60 cc's, that's what they're actually seeing here in this pressure volume curve. Okay, notice one thing, the heart never empties. The heart has always some degree of residual volume in it. Okay? Which you don't want to empty the heart completely because it basically makes the heart be like this. And then try to make it squeeze again. It's not good. You want to be able to have your hand squeeze down to that point and then be able to go back and then squeeze again. You never want to be down to here because then to go all the way back to where it should be is more difficult. So the heart never really tries to empty itself out completely. Does that happen? Yeah, usually when you hemorrhage to death. That's something you don't want to see happen very often. Okay? Once you get to a certain pressure, okay, the valve will close, and that valve closure point is the actual what's called a contractility point. Okay? It indicates to you the degree of contractility via this contractility line, which is seen here. Let me see if I erase this so you can see it better. This line here is a contractility line. Okay, notice that it's a line. It is not a curve. Sometimes books will make it confusing for you because they will talk about a Starling's curve and a contractility line to be the same. It is not. Okay? It is similar and has a lot of attributes that are similar, but it is not the same thing. Okay? A cardiac output curve, which is called a Starling's curve, is dependent on the preload point. Okay? That means this point. That generates this curve. Look at the curve and look at the line. Two different things. Now, does it mean that the contractility line is completely not related to Starling's law? The answer is no. It is related. Okay? If you improve the performance of the ventricle, the actual cardiac output curve will also shift and show that to be the same. Okay? But it's not the same thing. It's not a line. Okay? So this point here, which is when the aortic valve closes, is basically your contractility point. Now, when you're talking about preload changes, we'll tell you that you go up or down the preload curve. If we tell you about afterload, then you go up or down the afterload curve. And if you're talking about contractility changes, you're going to be going laterally or downwards. This is a decrease in contractility. This is an increase in contractility. If you're looking at afterload, this is an increase in afterload. This is a decrease in afterload. If you're looking at preload, this is an increase in preload, and this one's a decrease in preload. Okay? What I'm trying to get you to first understand is understand the model, understand how it actually looks at the left ventricle as it ejects during the whole cardiac cycle. The reason that I make you do it this way is I think it's one of the most effective ways of teaching you cardiac hemodynamics. Okay? If you begin to understand this model, any drug that comes out, you will understand exactly how it affects the heart, no matter how complicated the medication is. It also makes it a very helpful clinical model to make you understand where you're at and what disease state. When we talk about valve disorders, you will not have to memorize this for the boards. You will understand it, so when you get to your boards, you'll be able to pass the board questions on valve dysfunction. So make sure that you begin to understand this thoroughly, because this is not going away. Okay? Went through all this, so I'm going to keep going. Okay? So that's the preliminary discussion on that. Now, as you look at the blood flow that goes through the heart itself, the superior vena cava, I talked to you about that already. Yes? Yeah. Okay. What the contractility line basically tells you is how well the contraction is taking place. The more vigorous the contraction, the more vertical this line becomes. Okay? So if nothing changed, if the afterload stayed the change and the preload stayed the change, it's the same. If you gave them medication to say that just increases contractility would have no other effects, okay? What you would end up doing is you'd end up shooting out a cardiac output out here. So what effectively increased when you increase contractility? Stroke volume. Okay? And it also, what else did it do? It emptied the heart more than before. Okay, so your residual volume is less, which is another important concept. Okay? If on the other hand your contractility drops off, let's say you're developing a person who's developing ischemia, okay, and the ventricle is not able to pump, and we're not making any other changes. We're just keeping everything else steady. Okay? So we're keeping the preload steady, and we're keeping the afterload steady. And that's what I want you to do. I want you to keep one thing steady at a time for initially. In the real world, it doesn't quite do that, but we'll keep it simple first. Okay? If you see that somebody has a decreasing contractility, then that line shifts this way. Okay? And what will happen as a consequence is now when the person hits that afterload, they'll shoot out to here and then drop down. So what happens to your stroke volume? It decreases, but what happens also to your residual volume? It increases, and the heart stays fuller, so the heart begins to distend, which is why you see that, and you have somebody who has a myocardial infarction, the heart will begin to dilate on you. Okay, and this is all important concepts that you need to understand. Okay? Is that better? Okay. Now, blood flow through the heart itself, you have to look at it. We already talked about this before, so I'm going to skip through this. The superior and inferior vena cava, I already had that discussion earlier. You have also a residual structure here, which is called the fossa ovalis. Normally that remains closed, but around 20 to 25% of the population, it's a patently closed system. So if you have an increase in right atrial pressures that are high enough, they will open up the valve and cause a shunt effect that could take place inside the heart, but it's something that normally does not occur. The tricuspid valve has a 3-leaflet system connecting up to chorda tendineae that then connect up to papillary muscles. These papillary muscles become important when we talk about discussion later on about ischemia. The tricuspid valve usually does not become incompetent due to ischemia because the right side of the ventricle is actually perfused through the whole cardiac cycle. The left ventricle, on the other hand, is only perfused during diastole. The blood flow through the ventricle, if you look at from the pulmonic veins, the pulmonary veins are the ones that actually have the oxygenated blood returning back. There's usually 4 pulmonic veins coming back and eventually reach the left atrium. Okay? The left atrium then pumps through the mitral valve into the left ventricle. Eventually, it goes out. We have what's called an outflow tract, which is this, eventually going out to your tricuspid aortic valve. The importance of this anatomical description here is that this area here can sometimes will develop thickening, which is what we'll see when we discuss later on about IHSS, which is idiopathic hypertrophic subaortic stenosis, and you'll learn about that later on. Now, the next component of this discussion is going on to, besides anatomical, which is the muscle itself, but you also have to understand that inside the muscle itself, in the interior portion of the heart, is actually the conductance components of the heart, which is the electrical component. If you look at the actual heart the way it's set up, okay, if you look at it in layers, you have an outer layer, which is the epicardium, and in this epicardium is where the major blood vessels are running. Okay? And the next layer into that is the myocardium. Okay? And then the next layer inside there is the endocardium. And in between here, where the dashed line's at, it's called the subendocardium. That's where your conductance cells are running. That's where the electrical component is at. And why is that so important? If you look at the way the coronary arteries are out here, they send perforating arteries all the way down to here. So which portion of that tissue is going to have the least amount of oxygen delivered to it? And the answer is the endocardium and subendocardium. So before you see muscle changes, which is you'll see ST segment changes, you're going to see a lot of electrical disturbances first. You can go into left bundle, right bundle branch block from ischemia of these actual excitation cells. These specialized cells, they work to basically send electrical activity to the muscle surrounding it and cause contraction to work as a team. Okay? The SA node, which is located in the portion of the right atrium, is the one that it generates what's called the P wave. The P wave is the first portion of the electrical excitation of the heart, okay, that's generated inside the right atrium. And that basically, as it travels down these 3 conductance vessels, it causes the electricity to run through and around cells right next to it. So the cells that are right next to this have gap junctions. They actually talk to these cells directly. So, in other words, you don't have to have, like in the muscle, where you actually have to have an individual neurotransmitter connection to cause the muscle to contract. The heart works by the electrical activity dissipating from one cell to the next as a consortium. They work together. Okay, so when you see this, the atrium contracts. So right after the P wave, the atrium will contract and develop what's called the right atrial kick. And then this is followed by the left atrium contracting. So these things contract at a slightly different rate. Okay? The right atrium usually contracts first before the left atrium contracts. But visibly, when you see it, it looks almost the same time. But if you were to measure it at the microsecond level, there's a slight delay between the right ventricle firing first to the left ventricle, left atrium firing. Okay? When it fires, the mitral valve and the tricuspid are open, and it empties the last 20% volume, usually into both the right or left ventricle. So it really fills the tank. At that point, there's a delay that takes place. The electrical delay allows the mitral valve and the tricuspid valve to fully close, as well as completely finishing the contraction of the atriums. Okay? That delay is what we call the PR interval. Okay? The PR interval is that slight delay period. Okay? There's still electrical activity that's found in the AV node, but you just can't see it. But the cells inside here are holding it. There's two portions of this conductance component here in the AV node. There's a triggering component and there's a loading component. The first one is the loading. It takes the energy and loads it, just like a bullet, into a chamber. And then, as a delay waits, then the trigger fires in this lower portion of it. The trigger, once it fires, it emits electrical activity down the His-Purkinje cells, and then it dissipates into the ventricles, causing ventricular contraction to take place. Okay? So the lower one is very important in the sense that if you cause damage to that, you've caused damage to the trigger, it's a much more serious condition than if you fail to put a bullet into the chamber. And we'll talk about that in Mobitz 1 compared to Mobitz 2 as to what the disease process occurs. The effective work can only be done if you have several components all put together. You have to have synchronized cells, which requires electricity to do that. You have to have anatomically correct valvular function. You have to have proper opening and closure. You must have adequate muscle contraction, which is adequate contractility. You must have adequate filling of the ventricle as well, which is called the preload. And then you must not have to pump against too high of an excessive pressure, which is the afterload. Okay? And afterload is a complex concept. It's not just how much blood pressure is outside. It has to do with viscosity of blood. It has to do with reflectance waves. It has to do with the valve itself. So there's many different things that make up afterload. Now, one of the things that once you get to clinical, the way people are going to know that you know what you're talking about is somebody asks you about the heart. If I ask you about the heart in clinical and say, well, tell me what you think is going on cardiovascular, the first thing I want you out of your mouth is, well, I want to sort of figure out what my preload is, afterload, contractility, and heart rate. That's it. I don't want to hear about pressure. I don't want to hear about perfusion, warmth. I'm looking at heart rate, preload, contractility, and afterload. You have to think of the heart always that way, period. Okay? And that's why the pressure volume curve is for you, is to begin to make you think in that way only. Okay? You're no longer going to be told to treat symptoms. You're being now trying to figure out what's going on. This is what makes it more difficult. Okay? But the nice thing about it is you're not going to get fooled. Okay? If you begin to understand this, you will be able to manage anything that comes your way. Okay? As long as you understand preload, afterload, contractility, afterload, and heart rate. Okay? Now the first thing that controls the heart rate, heart and cardiac output is Starling's law. Okay? Under normal circumstances, under Starling's law, as you increase preload, okay, you tend to see a greater amount of stroke volume. Okay? So as preload increases, your stroke volume increases as a consequence. So what that is basically telling you is this is the preload curve. Okay? That if I start from here and went to this point, this person is going to have, if you keep going up this curve, normally the stroke volume continues to increase. Now above this point here, it no longer falls under Starling's law. That's considered what? Failure. Okay, so Starling's law only applies to normal conditions where as you increase preload, stroke volume increases. Above that, then you're considered into the failure curve. Now, here's a difficult concept for most students. Okay? Most students, when they ask me what is really preload, they get confused. Okay? The best way I can give you is an analogy. Okay? Your muscle inside your heart basically requires to have so much volume in it to work efficiently. Okay? And it's the same thing if you were to think about a skeletal muscle. So I'm going to give you a skeletal muscle analogy first, and that'll fit in with the actual cardiac muscle. If you were to ask to lift something really heavy, okay, you will notice that the first thing you will do naturally is that you will not put your arm out straight like this. Or you won't put your arm like this. Okay? If you did this with your arm and you try to lift something heavy, this is what we call low preload. There is the actual muscle is so close together, the sarcomeres, that they can't contract. So if I try to pick up something really heavy like this, I would have to use my back muscles. My arm muscles wouldn't be able to help me at all. Because at that point, my preload is basically 0. So you can't lift anything at that point. Okay? If, on the other hand, I'm overextended like this, that's an overdistension of my muscle, and you will notice that your performance actually drops off. Okay? That's the same thing that happens with the heart is nicely big and dilated. Okay? It's too much. The actual ventricle and the muscle can't, the sarcomeres are so far apart they can't contract properly. So if you see somebody really want to lift something heavy, they'll put their arms at about a 15 to 20 degree mark, okay, and then lift from there. Because that gives you the optimal amount of sarcomere distance to give you the most contraction. And that's what the heart's trying to do. The heart's doing the same thing. The Japanese did this great study, which they actually took a sarcomere. So this is actually a experimental study. They took an individual sarcomere. And I showed you this before in the pictures and the cellular physiology and muscle. Okay? Imagine taking that little guy and putting it under a tensiometer, okay, which means it's a device that measures tension. And what they did was they separated out the thin and thick filaments. Okay? If they kept it at around 2 micrometers in distance to 2.4, they found that the amount of contraction considerably continued to improve. Above 2.4 or 2.3 in this example, the performance dropped off. And that's the same thing that happens with your ventricle. We, instead of measuring it in actual sarcomere length, we measure it in volume. Okay? Just think of the ventricle being at this point here, which is going to give you great contraction. If you're down where the ventricle is completely empty, that's you're here, or the ventricle is very grossly distended, then you're here on this portion of the curve. So you want to be in the right portion of the preload before contraction takes place. It'll tell you how well the contraction takes place. Right. Does that make sense so far? Hard concept to get. If not, just when you think about it, we'll come back to it a little bit later on. What actually controls the contractility of the heart is only the sympathetics, the ventricle at least. Okay? The parasympathetics control heart rate, and it also can affect atrial kick, but it does not affect the tone or the contractility of the left or right ventricle. Okay? Sympathetic nervous system, of course, is regulating as well. Increasing heart rate by norepinephrine is the main neurotransmitter. It uses beta receptors in the heart, beta 1, to increase heart rate and increases the action potential conduction velocity called the dromotropy. And trust me, you have to know that terminology, dromotropy, as well as the inotropy, which is the contractility of the heart. I wish they could just leave it as potential conduction velocity, but the boards have recently changed that into using the words dromotropy and inotropy. So sympathetics control heart rate, as well as parasympathetics also control heart rate. Contractility, though, is only for the ventricles by sympathetic. Here, the note is only the atrium is a parasympathetic. Okay, there's no effects on the ventricle itself. Conduction velocity is increased with sympathetics and is affecting by the parasympathetics as well. The blood vessels, there's no effect on blood vessels by parasympathetics, but you do get effects, capacitance as well as resistance, which is the arterioles that are controlled by sympathetics. So sympathetics really control most of the circulatory management that you're seeing. The reason all that's important is later on when we talk about how the heart, how we do spinals and now we actually suppress the sympathetic nervous system, this will become quite evident. The parasympathetic system is the vagus nerve, okay, which is part of the autonomic nervous system. It's the cholinergic muscarinic receptors, which is located in the SA node, AV node, and atrial muscles. They decrease the chronotropy, which is the heart rate. They also decrease the action potential conduction velocity, the dromotropy, and the force of contraction of the atrial cells only are affected as well. They're suppressed. Then we'll stop here and start vasculature next. Give you guys a 10-minute break.